speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. And just a quick reminder, attendees have not been given the permission to record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speakers is illegal. We thank you for your understanding, and with that, Hillary will kick off the session.
Hi, everybody. Welcome to 2024 and our first case session of the year. I have the honor of introducing Dr. Philip van Hanneker, who is a renowned and accomplished musculoskeletal radiologist who needs no introduction. There, I'm done. No, seriously, he is a longtime staff radiologist at a hospital that is apparently pronounced differently depending on which language you're speaking. I'll butcher it. It's, I think, something like Mechelen Hospital in Belgium, and he is a consultant radiologist in Antwerp and guest lecturer at both Antwerp and Ghent. Apropos to today's focus, Philip has authored and edited publications focused on imaging soft tissue tumors, but he's contributed to over 400 peer-reviewed publications. He's been active in leadership roles of both the ESSR and Belgian Society, as well as many other societies. Okay, Philip, please share your screen.
Okay. Can everyone see my screen?
Yes.
Yeah, okay. We are ready to start. First of all, thank you very much for your very kind introduction, Hillary, and thanks for the invitation to speak here on this forum. As Hillary pronounced very well, this is the main building of the hospital where I do my main clinical work. And of course, you can see also that I am affiliated with the University of Ghent and Antwerp. So what I will try to do is to present you a rare cause of a painful elbow. I have no disclosures related to this presentation. And it's a 43-year-old male who performs power training, but no other sports. And he had a history of long-standing pain and a steroid injection in the elbow. So the pain was shooting, medially located, and very, very painful at palpation. And initial ultrasound was not possible, and he was referred first for an MR after a plain film. You can see here on the lateral view that is unremarkable, but if you look very carefully here at the anteroposterior view, you can see within the subcutaneous fat a lesion here, non-specific density. This is the MR that was performed because the ultrasound was initially not possible. On the T1 weighted images, you can see a lesion which is well demarcated, well delineated. It's not touching the fascia of the muscle, it's touching the dermis, but also here we have some preservation of the fat pad between the lesion and the cutis. On T2 weighted images with fat saturation, you can see that the lesion is hyperintense. Also here on the oblique coronal images, it's rather well delineated, but there are some vessels near the lesion, here at the top of the lesion and here more distally. This is the T1 weighted image with fat suppression, and after contrast you can clearly see that there is vivid enhancement of the lesion, which is further proven on the subtraction images. You can see that the fat is still preserved or partially preserved between the skin and the lesion, and also there is no involvement of the muscles. This is the oblique coronal image You can see the vivid enhancement. There are some vessels here at the periphery of the lesion. We try to motivate the patient to do once again an ultrasound without any pressure and a lot of gel. And you can see that the lesion is indeed well delineated. It's a solid lesion. And when you put on the Doppler, the power Doppler especially, you can see that the lesion is highly vascular. Because the lesion was so painful and because it was vascular, a biopsy was not performed and the patient was referred for resection. About the imaging differential diagnosis, you could consider a neurogenic tumor, but there was no adjacent nerve visible. Epidermal cyst, this would definitely not fit because it's a solid lesion and in addition, it's very vascular. You always have to think at lymphadenopathy in a patient with catch-scratch disease, but serology was negative and there was no history of catch scratches at the dorsal aspect of the hand. So this was excluded as well. Metastasis, I don't see often isolated soft tissue metastasis when there is no history of an oncologist for previous oncology, so that was excluded as well. And we thought at the possibility of an angioleiomyoma, which is often superficially located at the limbs and is also highly vascular. But anyway, the differential diagnosis was still open for other possibilities. So you can, if we summarize here, a well delineated solid lesion, highly vascular on power Doppler and on MR. Finally, the diagnosis was made by histology, and you can see here the regular stainings. Here you can see at the macroscopic view that the lesion is indeed well delineated. And when you look at the more enlarged views here at the periphery, you can see that the lesion contains vascular structures, which are lined here by endothelial cells, and they are surrounded by nests or trabecula of uniform glomus cells. If you look here at the other side of the lesion, besides the presence of glomus cells, you can see the presence of hyalinized or myxoid tissue within the lesion. And this is the capsule of the lesion. If you do the other stainings here, once again, this is an enlarged view of the regular stainings where you can see the vascular structures surrounded by glomus cells. And if you do CT31, you can see that only the endothelial lining of the vascular structure is positive for that staining, while the other stainings, smooth muscle actin and vimentin, are positive for the surrounding glomus cells. So the diagnosis was made basically on histopathology of an extradigital glomus tumor. So what is a glomus tumor? You all know what it is. It is best known at the ungual areas, at digital, in young females. It's a neoplasm composed of cells from the glomus body. And what is the glomus body? It's a contractile neuro, myo, and arterial structure, which explains that it's very painful clinically, and it enhances much after gadolinium because there are a lot of vessels in the glomus body. It regulates the blood pressure and stands for the thermoregulation by altering the cutaneous blood flow. The benign lesions are much more frequent than intermediate lesions, along with the classification of the WHO, and malignant glomus tumors are very rare and are also designated as glomangiosarcoma. Solitary lesions or sporadic lesions are much more frequent than multiple glomus tumors, which may be an autosomal dominant inherited disease, and it's called cholangiomatoses. The digital form is typical, occurring in young females, while the extradigital, like in our case, occurs in an older age and usually males. Clinically, there is a typical triad of tenderness at the level of the lesion, typical pinpoint pressure pain, which was present in our patient, and in the typical case, at the fingers, there is cold sensitivity, which is often absent in the extradigital subtypes, as in our patient. So, because the clinical triad is not always present in the extradigital subtypes, there is often a delayed diagnosis, and patients are complaining for many years before the diagnosis is finally made. On ultrasound, it's a solid lesion, highly vascular, and this is important. While you do the ultrasound, you have to think at the possibility of the glomus tumor, and if you have specifically pinpoint pressure pain when palpating with the lesion with the ultrasound probe. On MR, it's non-specific. ISO intense to muscle on the T1 weighted images and hyperintense on the T2 weighted images. It enhances vividly because of the arterial structures within the lesion, and it's usually well delineated. The final treatment is complete resection. This is what you all know, the typical subungual type in a female. You have here the nail bed, you have here the tumor, which enhances on power Doppler, and there is often in long-standing cases the presence of pressure erosion on the cortical bone. Here on the axial images, once again, pressure erosion on the cortex of the distal phalanx. On MR, non-specific but highly vascular, but you can see it if you have, once again here on the T2 weighted images, high signal intensity, so signal intensity is a bit non-specific, ISO intense on T1, but here typical location under the nail bed and pressure erosion. Also here, after gadolinium, vivid enhancement and pressure erosion, which is better seen here on the axial images. So this is the typical case, you will not miss it. Regarding the extradigital cases, it's much more rare and there's often a delayed diagnosis. There was a review about 15 years ago in our own journal, the Journal of Belgian Society of Radiology, by the group of Peter Munk, where they performed a review of those extradigital subtypes, and they all look very similar as our case. Non-specific signal intensity, hypo on T1 and hyper on T2. There are some cases where gadolinium was administered, and when gadolinium is administered, there's a very vivid enhancement. So in conclusion, the extradigital subtypes of the glomus tumors are rare. You have to think at it if you have highly vascular solid lesions. The imaging findings are non-specific for the extradigital glomus tumor, but you have to think of it if you have typical pressure pain at the area of the lesion while performing ultrasound. So it's very important to add that information and use it in your differential diagnosis. It's often a lesion which is long-standing, and when it is vascular and solid, located in the subcutaneous fat, you should think at the possibility of a glomus tumor. This is a nice other review, a more recent, where all the published cases are summarized and reviewed, so I can recommend to read this article. I have to acknowledge my clinical colleague, Frédéric Catry, And so finally, I want to do some promotion for our European Society of Musculoskeletal annual meeting, which will be held in Lugano in Switzerland. So thank you very much.
Thank you very much, Philip.
I will try to.
Our next speaker today is Dr. Shivani Ahlavat. She's an associate professor at the Russell H. Morgan Department of Radiology and Radiological Science in Johns Hopkins School of Medicine, and also serves as the Musculoskeletal Imaging Fellowship Director. Dr. Ahlavat's clinical and research activities focus on advanced MRI techniques, specifically the detection and characterization of peripheral nerve injury and soft tissue tumors, including peripheral nerve tumors, particularly in the setting of peripheral nerve tumor syndromes. Her areas of interest include whole body MRI in the setting of neurofibromatosis type 1, NF2, and schwannomatosis, with emphasis on quantitative non-contrast MRI techniques such as diffusion-weighted image and apparent diffusion coefficient mapping in characterization of bone and soft tissue tumors. Please share. Oh, you already shared the screen.
Thank you so much, Hillary and Emily. As you said, my name is Shivani. I'll be talking about a 26-year-old woman with ankle pain. These are my unrelated disclosures. So a 26-year-old woman presented to our orthopedic surgery department with mild left foot pain and swelling for about 1 month. And the pain was characterized as aching and pinching. It was located anterior to the lateral malleolus. She had some difficulty with walking, but reported no prior relevant traumatic history. She had no relevant past medical or surgical history. On exam, she had moderate tenderness overlying the lateral malleolus. And the exam was significant for a palpable soft tissue mass measuring about 1 centimeter, located anterior to the distal fibula, which was mobile, and changed size with plantar flexion and dorsiflexion. So she underwent radiographs, and we don't see anything really in the area of interest overlying the lateral malleolus or distal fibula. So the assessment per the orthopedic surgery department was possible ganglion cyst and left ankle pain of unspecified chronicity. So they were still interested in some orthopedic injury, and as such, they proceeded with an MRI. So these are sequential axial, T2 fat suppressed and non-fat suppressed intermediate weighted sequences through the area of interest. And there's a clinical marker denoting where she feels this abnormalities. So we see a soft tissue mass here that's T2 bright and has some ill-defined soft tissue edema around it. And it has some internal complexity with this hypointense whorling type appearance centrally. And it can be better seen on the intermediate weighted sequence here. And you might think that this is a target sign associated with a peripheral nerve sheath tumor. And those target signs usually occur in both neurofibroma and schwannoma, but they tell us about the internal architecture of a tumor, and they should really be perfect. Sort of a central hypointense rim due to fibrous center, and a myxoid-rich periphery that gives us a bright T2 signal in the periphery. And our patient didn't quite have that. So it was not a target sign. You might think that these look like internal fascicles if you look on sequential sagittal images. And fascicle sign we see, again, often in the setting of schwannomas, not so much neurofibromas, and they're ring-like structures or almost noodle-like structures within a tumor, possibly reflecting fascicular bundles seen histologically. And these didn't quite have that. They looked interrupted and had internal complexity, so it didn't quite meet criteria for a fascicular sign either. And then on sagittal images that were somewhat off-center from the lesion, you see these sort of tails emanating proximally and distally. And you might think, oh, is this a tail sign? And a tail sign we see when there's a mass in continuity with the neurovascular bundle. But in practice, it's usually in occurrence with a large named nerve. And we don't really have a large nerve there. So this was not a tail sign, but rather just perilesional edema that was emanating proximally and distally. In our practice, we tend to do diffusion-weighted imaging pretty frequently. And qualitatively, when you look at images, this is our soft tissue mass of interest. Between low, intermediate, and high B values, it looks like it's losing signal. However, on the ADC map, there's still some areas of hypointensity, which when we draw an ROI, had low values. And in our practice, we've been doing it for about 12 years. We tend to use a threshold of 1 to determine benign versus malignant. And so it seemed suspicious on ADC values. Then we looked at our T1 fat suppressed sequence, and we see that there is internal interrupted enhancement of the soft tissue mass. So at the end of any soft tissue mass that I try to classify, I try to say whether it's a benign known entity. So for me, this did not meet any criteria of a known entity. It didn't fit the exact bill for a schwannoma neurofibroma. It was definitely not a ganglion. I didn't think it was probably benign based on the ADC characteristics. So I was in the C or D category. I went with suspicious for malignancy, and our patient underwent a biopsy. And on biopsy, it was found to be a synovial sarcoma, the monophasic type. And on immunohistochemistry, it was strongly and diffusely positive for TLE1 and EMA. And SS18, SSX gene fusion was detected on this particular mass. So synovial sarcomas are the 4th most common type of soft tissue sarcoma, and they present with a median age of 35. So our patient, a 26-year-old woman, was somewhat younger. However, about almost 20% tend to occur in younger people, children and young adults, with a slight male predominance. They tend to occur anywhere in the body, but most likely in the extremities. And there are various different histologic subtypes, but there's nothing we can tell based on imaging. So a biopsy is required for a mass like that. And the diagnosis is confirmed by molecular or cytogenetic testing, which is typically done. Literature suggests that synovial sarcoma, which is really a misnomer, it's a periarticular soft tissue mass, not an intraarticular, with a small subset that are calcified, 30%. So ours was not. And they can have multiple lobules like this, and they can have a bowl of grapes sign, which is comprised of admixture of hemorrhage, fluid levels, and septae, as we see here. So there's a septae here, fluid levels, numerous ones, and hemorrhagic products within this lesion. They can also exhibit a triple sign or marked heterogeneity on T2 weighted images, which our patient did have some heterogeneity. And this is characterized with mixture of high, low, and intermediate signal within the soft tissue mass. So this is a really nice paper from pediatric radiology looking at soft tissue masses in young patients. And what they did was try to distinguish imaging features of synovial sarcomas that were in the axial or proximal appendicular body versus distal appendicular, like our patient. And so distal lesions, as we would expect, tend to be smaller because they present sooner, they're palpated sooner. They tend to lack the triple sign, and they tend to be more homogeneous. Meanwhile, the axial and proximal lesions tend to be uniformly heterogeneous on T1, T2, and post-contrast sequences. In addition, distal lesions tend to be mostly solid, while that's not the case with the axial and proximal lesions, and they often lack calcification. So ours did meet these characteristics. 2 features associated with synovial sarcoma that can lead to delay in diagnosis or confusion with an indolent benign process is slow growth. Average time to diagnosis can lag by 2 to 4 years, and small size, which is common with superficial soft tissue masses and distal lesions. So size alone should not stop us from biopsying something we don't think is completely determinate on imaging. In our practice, we often use diffusion-weighted imaging and use it as a quantitative tool by drawing an ROI, and lesions that are low on ADC map and exhibit low ADC values tend to be hypercellular or malignant, and so we chase those more aggressively. This has been shown in other people's experience as well, where particularly a less experienced reader tend to increase their accuracy with incorporation of diffusion-weighted imaging in their practice. It doesn't quite work for someone as more experienced who's seen lots and lots of sarcomas, but not everyone encounters them pretty routinely. And this was also concurred with additional study that was done in 2016, where a less experienced reader gained accuracy by inclusion of diffusion-weighted imaging. So beware of distal, peripheral, small, soft tissue masses. If they're indeterminate on imaging, they still may be sarcomas and they should be pursued more aggressively. And diffusion-weighted imaging can serve as a useful adjunct tool in deciding how to manage that patient. Thank you.
Wow, wow, wow. Those are two fantastic cases. Yulia, what a tough act to follow.
I know.
I know,
I'm
right?
getting anxious. Thank you.
It's okay. I'm anxious for you. Okay.
Okay.
So Dr.
Thanks,
Yulia
Hillary.
Melanevsky is my good friend. I'm thrilled to introduce her. When we ask for a brief bio, she, like provides 3 words. She's very humble. She attended medical school in St. Petersburg, Russia. You might notice the accent. She did her residency and MSK fellowship at Beth Israel Deaconess Medical Center in Boston. I think there's a hint of a Boston accent, right? And
Not
she's
anymore.
currently an assistant professor. What?
Almost an associate, I think.
Oh, so you didn't update that. I was a little
No, not
disappointed.
yet, but almost. Next time.
At the University of Alabama in Birmingham. She's the MSK Fellowship Program Director, and her fellows are very fortunate. Her interests are in trauma and orthopedic hardware, tumor imaging and intervention, and adult education. So hopefully she'll teach us something. I have to say that Yulia has been the game master of our small forum OCAD live meeting now since 2019, having developed a valuable teaching tool for her trainees that she's adapted into a fun and very challenging and competitive game that's consistently been voted our favorite at the meeting. I'm looking forward to playing in Puerto Rico with Yulia very soon.
Thank you very much. Thank you, Eleni and Hillary, for the invitation, and thank you so much for the kind introduction. I appreciate it. It's always fun to present in a meeting. Here you go. Starting the case. I have no disclosure, sadly. Still no disclosures, and let's get on with the case. This case is a case of a 69-year-old lady who presented to the emergency department at UAB with several weeks of right upper extremity pain and swelling, as well as functional decline. History: we were provided with pathological fracture of the right humerus, right plasma cell mastitis, biopsy proven, recurrent right pleural effusion with thoracostomy tube. From laboratory data and imaging, we were presenting with a CT of the chest done for PE, I think, and there was a large pleural effusion on the right with an indwelling pleural catheter, multiple left pulmonary emboli, and asymmetric body wall and breast edema. She had some leukocytosis and thrombocytosis on the initial lab work. On radiography, she has a very large primitive lesion in the humeral proximal diaphysis. There is a pathological fracture, as you can see, and there's marked cortical thickening as well. Here it is in a little bit of a close-up. There's also a lytic lesion in the ulna. More lytic lesions in the ulna, and as you can see, massive soft tissue swelling and mass. On CT, which we promptly obtained, you've got a humeral head and neck erosion filled with soft tissue. CT of the antecubital fossa demonstrated a large mass-like lesion with very dilated vessels, also erosions. MR, I apologize in advance. I gotta say, I am very jealous of other presenters for beautiful MR imaging. This lady did not hold still for us. So we do appreciate preserved bone marrow, except for the site of the fracture. There's an erosion filled with fluid sensitive, high soft tissue and diffusely abnormal muscle. This is the site of the fracture right there. Here you go. Long head of the biceps tendon is actually going through that mass. The pattern of the soft tissue mass is infiltrative, and there's infiltrative lesion that we appreciate on MR as well in the humerus. The blood vessels are tortuous and dilated, and the enhancement is heterogeneous. The mass actually extends through the soft tissues to the dermis, and there's some subcutaneous and soft tissue edema as well. So what is our differential diagnosis at this point? Because we are down to MR, so we got to come up with something. So could this be an infection, kind of multi-compartmental, extensive, aggressive bone lesion? Could be. The hypothesis of bacterial infection is supported by leukocytosis. However, there were no systemic symptoms and no abscesses in the muscle, so maybe not. Viral, she had no viral symptoms. Fungal could be looking like anything, right? Neoplasm, sarcoma of the soft tissue, including angiosarcoma and Kaposi sarcoma. Leukemia, lymphoma, it's a little too extensive for that kind of tumor. And to consider primary bone tumor, we should compare the extent of soft tissue and bone pathology. But that's that. Other entities would include dermatomyositis and polymyositis. It should be lower more than upper limbs. We don't expect to see such bone lesions. And so maybe less likely lower on the differential list. Medication-induced myopathy. Some medications will cause severe myositis and myopathy, but we don't expect it to affect the bone as much. Now, trauma could be extensive hemorrhage and myonecrosis, and finally radiation therapy is what we came up with, and we try to get to no major trauma and no radiation therapy. So, well, that's that. Further imaging we obtained was ultrasound. And this was obtained overnight, of course. It was an urgent overnight ultrasound, which demonstrated a heterogeneous mass labeled antecubital fossa. We discovered echogenic tubular structure, sort of what we saw on CT. Again, huge mass, subcutaneous, and within the mass, there are tubular echogenic structures. Compare these look very similar. So are these dilated vessels? There's slow flow, maybe enhancing thrombus. Not clear from now. Power and color Doppler demonstrates very extensive vascularity. There are some cystic areas, echogenic septations, and hypoechoic spaces as well. So is there thrombus? Maybe. Okay. So what do we do with that now? I mean, I think we've done enough imaging. We need to biopsy. So the biopsy was obtained of the soft tissue in the erosion right here, and I did this biopsy. The patient was not very ill appearing. She was no distress. She let me biopsy the soft tissue erosion, and she did not need sedation or anything like that. The arm was definitely very edematous, and that's what the patient looked like. So I included the CT image corresponding to where we decided to biopsy. I scraped a little bit of bone from the bottom and mainly biopsied the soft tissue. And so what did the pathology reveal? It was a hemangioma. And seriously, all that is hemangioma. So nobody believed us. and it was biopsied again. It came back non-diagnostic. And then the third biopsy, we biopsied everything that we could see. So I biopsied the soft tissue within the erosion. I biopsied the bone of where the erosion was. I biopsied the muscle over it. So everything was biopsied. So we had to get a diagnostic result. So pathology returned with the diagnosis of vascular tumor with innumerable finger-like projections in the epithelial-lined vascular spaces and central organizing thrombus. This appearance is consistent with intravascular papillary endothelial hyperplasia, also known as Masson tumor. There was no intralesional necrosis and no cellular atypia, which is very important for this diagnosis. Each separate biopsy, both humerus erosion and surrounding muscle, had the same diagnosis with hemangioma with features of Masson tumor invading the surrounding bone. So in her hospital course, the lady got significantly worse at baseline, and it looked like even by the end of her stay, she had more bone destruction and more soft tissue, extensive soft tissue growth in the chest wall. The patient was getting very, very sick. She got into septic shock and died in the ICU 4 days after the final biopsy. We did an autopsy, and that revealed hemangioma in the humerus with thick-walled vessels and endothelial proliferation with hemorrhage in the growth pattern of, again, our intravascular papillary endothelial hyperplasia. Same histopathological findings were present in the right upper arm soft tissue, and of note, the skin of the right chest wall and upper arm was hyperpigmented. So let's talk a little bit about what we see. Soft tissue hemangioma is very, very common. It occurs in superficial or deep soft tissues, and bluish discoloration of skin can be observed when the mass is superficial, slow flow vascular malformation. So of note, vascular lesions, including hemangiomas, are immunoreactive with vascular markers CD31, 34, and ERG. Deep soft tissue hemangioma can produce reactive changes in bone. It can present with erosions, reactive bone formation, and osteopenia, as well as cortical tunneling. Pseudopermative appearance is attributed to marked hyperemia-induced osteoporosis from the adjacent lesion. Now, what is this intravascular papillary endothelial hyperplasia? It was described by Dr. Masson in 1923 as a tumor, intravascular hemangioendothelioma, and because I was going to present it last year, here's happy birthday to the IPEH. And so interestingly, this tumor he described in the sample of a hemorrhoid. So first described in the hemorrhoid, this one. So IPEH is more accurate description of histology because it's really not a tumor. It is a benign proliferation of endothelial cells associated with a thrombus. It is really not a tumor. It is a reactive process, exuberant form of organizing thrombus. Why some of us react in such a form, it's not known. We still don't know. Some people attribute it to trauma because of the fibroblast growth factors released from endothelial cells in trauma. In turn, it leads to more endothelial proliferation and then again more growth factor and so on. But a lot of patients don't recall any history of trauma. Due to slight female predominance, very slight, it's been postulated that maybe origin is hormonal. But again, we still do not know. On histology, which I got these very nice images from a fabulous website, Pathology Outlines. They will teach you even if you know nothing about MSK tumors. So there are numerous papillary structures, which cores of fibrin outlined by single layer of endothelial cells. And here are the CD31 positive endothelial cells. And this is consistent with the diagnosis of IPH. Here it is in the, well, I could say high power, but I really just enlarged the image. So here it is, cores of fibrin and fibrous tissue and single layer. To call it IPH, this cannot contain any high-grade atypia and no necrosis. Right. There is a classification of a different classifications use slightly different nomenclature, but overall it is divided into classic or puriform, which arises primarily within a vessel. They're usually small and very superficial. Secondary or mixed form arises within pre-existing vascular lesion, which I think we image and biopsy most of the time because they can be larger and deeper. And extravascular is extremely rare, and it might arise within the hematoma. So primary, as I just mentioned, it is very commonly superficial and occurs in hands, neck, and head. They usually visible on physical exam and well circumscribed on imaging. But if there's extravascular extension secondary to rupture of the vessel, then they could be a little less well defined. Most commonly, I searched the PATH database in our institution, and most of them are dermatopathology. So, and very uncommonly, it is surgical pathology samples. On imaging, here is a primary form of IPH arising within the vessel. And there are certain features that we can evaluate here. On T1, it's either iso-intense or slightly hyper-intense. On fluid-sensitive imaging, it is peripherally hyper-intense with some heterogeneous intensity within the lesion. On T1 fat-saturated pre-contrast imaging, here it is slightly hyperintense to muscle, particularly little rim, and peripheral enhancement on post-contrast study. They can have central enhancement depending on the age of the lesion as well. Here is another example. So this is a lesion that we would say it's just a hemangioma, right? So phlebolytics, soft tissue mass, slightly hyperintense on T1, bright on T2, and enhancing heterogeneously. Since it was in the finger, we were asked to do a biopsy. They did not want to take it out without a biopsy. Here it is. This is an ultrasound. It's lobulated, hypoechoic, and the mass was vascular. It was also bleeding quite a bit. The diagnosis came back as, of course, hemangioma with type 2/mixed /secondary IPH. Here's another example of hemangioma with papillary endothelial hyperplasia. This looks like a relatively aggressive lesion with cortical breakthrough and component extending into the spinal canal and intensely enhancing on post-contrast images. Right here, this was bleeding also a lot on biopsy. So this came back as hemangioma with IPH. This is an example of secondary AV malformation with secondary IPH as well. So you can see that there is some fat within this lesion. It is heterogeneously bright on fluid sensitive sequences and heterogeneously enhancing. This lesion is intramuscular. So we saw some examples, some review of intravascular papillary endothelial hyperplasia, its features, and we looked at the very fascinating case of a rapid growth of multi-compartmental soft tissue hemangioma with IPH and intraosseous extension. And some points of this case also are that hemangioma with corresponding IPH can have a very aggressive appearance. It's one of those that are uncommon but could also be considered in these cases. I thank you very much for your attention and welcome questions.
Thank you very much, Julia. We have a question from the audience. I think it's for Philip. He said, excellent case, thank you. Is there any relationship between this glomus lesion and the traumatic history of the patient?
To my knowledge, there is no clear relationship with a previous trauma. Often those patients present with long-standing pain up to 15 years, and they cannot remember a trauma anymore. However, there is one case report when doing all the review, going through the literature. There was one case report published in 21, I think, on digital glomus tumor, which was post-traumatic, or the patient had 15 years ago a crush trauma. I don't know exactly what the relationship with the trauma could be, but it's not a constant feature.
Thank you. Dr. Serene Gia says that he had recently a case with a very painful tumor inside the conchoideus muscle, and he shares beautiful images of the tumor, and he did not know at the time that could be glomus tumor, and surgery will clear this soon, he hopes. And he thanks everyone, saying that this is amazing. Do you have any other questions?
I have a question, maybe it's stupid. Julia, it seems that this humerus was melting away. I know that there's a vascular component to Gorham's disease. Is there any relationship between the sentinel?
I don't believe so. I don't believe so. They described it as hemangioma with Masson-like features. And I have a question in the chat. Are there any pre-existing lesion or recent that are proposed for Masson tumor? So yes, so there are 3 forms, right? There's primary within the vessel, so there's no underlying lesion. So there's just, for no good reason, it occurs there. And the reasons proposed are, but we're not sure. It could be some trauma, or it could be hormonal factors, since there's slight predominance of females for this entity. Yeah, the path did not say anything about anything like Gorham disease, so we think that it's just melting away from such hyperemia and invasion of bone by this hemangioma.
Fantastic cases, I have to tell you, all of you, this was just outstanding. Thank you.
Yeah, amazing. Thank you very much. Thank you all for tuning in. The next session of this series will be held on March 22nd with a focus on sports image. Thank you all. See you next month. Bye.